Well, that's a very good question, because the biggest gap is actually of what is possible and what has been published and what the implementation is. Because we know for many years already that radiomics is capable to prognosticate patients much better than what we do now with the TNM stage and so on. So there's an improvement in the prognostication. Second, and I think this is really something what can be implemented in short term, that is that radiomics is also capable to see much faster than a shrinkage of the volume of a tumor on in imaging whether the patient will respond to a systemic treatment. And that is advantageous because you can switch earlier to another treatment if necessary. So that is something what is known already for a long time, and still it's not implemented. And I think that one of the key reasons was actually that the radiomics researchers were more busy with improving techniques than by implementing this in clinical practice, actually what were the clinical practice questions. But on the other hand, what we see the last maybe 3-4 years, that is changing, and I'm pretty optimistic about the implementation. What we see actually is that people now believe the results because they are so robust, they are really reproducible and so on. And many applications, so what I told you about prognostication, early response assessment, but also looking at molecular characteristics and even differential diagnosis between different types of complication what patients have, well, they are more and more let's say, believed, and therefore they will also be implemented. The biggest challenge actually is to standardize a little bit more the way that the standard of care scans are acquired. So when there's some changes between protocol A and B, between hospitals and machines and vendors, that's still okay. Many radiomics researchers work on that. But still, it would be good that at least there would be less variability in acquisition of some images in order to implement this easier in clinical practice. And I think that is one big challenge. And the other big challenge is, of course, that we need good data. That's to say, not only enough patients, but also external validation. I say 3 times validation in order to really make sure that the results are just not by coincidence. And when we do that, you will really see, like has been published already, that it's really robust. And then it's a matter of time to implement this.